We're very excited about our speaker today, our friend, Dr. Melissa Ruiz. And her journey started at Georgetown University, where she got her Bachelor of Science and then did her Doctor of Medicine at Columbia University. And then she had a career that started as a as a surgical resident before she saw the light of day and became a pediatrician doing her pediatric residency at the University of Illinois. She then was chief resident for the University of Illinois Hospital and Health Systems, and she was very active in that role. She helped create and then co-direct the community health advocacy tract at the Children's Hospital. She also worked with program directors there to work on a curriculum addressing child poverty. She worked at Kaiser Permanente Southern California as a community medicine fellow, working in FQHC, in the Hollywood Free Clinic, and at the Hollywood High School. And she did several projects during her fellowship. And then she started working at the Pediatric Diagnostic Center in Ventura County as a pediatrician. That FQHC focuses on caring for children with complex needs, and that's a particular interest of hers. She joined us about a year ago and is an associate program director of the pediatric residency and works at Santa Barbara Neighborhood Clinics as a primary care pediatrician. And as if that is not enough, she also is the chapter president for the American Academy of Pediatrics California Chapter 2 and is involved in several projects in that role as well. Today she's going to be talking to us about understanding and addressing the health needs of immigrant children. Dr. Melissa Ruiz.
Thank you, Dr. Frazier. You just summarized the last 26 years of my life. That's crazy. I was like, oh my God, that's a lot of information about me. So happy to be here. Thank you for everyone, both everyone who's here and then everyone online who's taking the time to listen. This is a topic that is very near and dear to my heart, and we'll talk a little bit about why. But I really appreciate you taking the time out of your busy morning, because I very much understand how busy our mornings are. And I'm very excited to be giving my first grand rounds at Cottage. We'll be going through these learning objectives, but really my goal for today is that you leave here with a little bit more information on how to best support our immigrant children and really our immigrant families, both that you care for, but really like in our community, right? And perhaps in our own lives, perhaps within our staff, but really coming out of here with some concrete tools and information to help support our immigrant families. The residents are probably sick of me saying this, but essentially anytime there's any diagnosis and you want to know something about it or want to know how to take care of a kid with that, I say just like Google AAP blank, right? So like we had a kid diagnosed with neurofibromatosis, say Google like AAP neurofibromatosis, you'll find the clinical practice guideline or the policy statement on that. Same thing with immigrant health. So if you Google like AAP immigrant health and maybe throw in toolkit, you will come to this toolkit. And a lot of this presentation is based around this very thoughtfully designed toolkit that came out a number of years ago, but has been updated and really is constantly updated. I do want to go over a couple definitions, because when we talk about immigrant children, if you look at any of the AAP policy statements and this toolkit, immigrant children are defined as both children who are foreign born or children born in the United States who live with at least one parent who is foreign born. So about 25% of children in the United States live in an immigrant family. And the vast majority of these kids are actually born in the US, and that matters for status and what resources you can access. We'll talk a lot more about that. This is a topic that's near and dear to my heart because I am an immigrant child myself. I am there. You'll see like my little baby pictures with curlers in my hair. That middle picture is my mom and my sister, and my parents were from Peru. My mom did not necessarily look like she was from Peru, and we could talk all about kind of the nuances to that. But I think growing up as a child of immigrants led me to kind of the path of wanting to be dedicated to taking care of immigrant children. And in fact, I kept my name in part, my maiden name in part because of that, because I wanted families to know that I could relate. This is my mom in front of some ruins near the town that she grew up in, which is in northern Peru, Trujillo. That's myself and my husband, much younger. I think we were like still in college maybe, or had just graduated college, in our traditional dress in the village of Peru that my grandparents grew up in and doing a traditional festival. And then that's my dad, current, more present state, with my boys and myself. But just knowing that that I had an immigrant family experience growing up really led me to a commitment to work with this population. But I also recognize that the path that my parents had is so different than the current path that many of our immigrant families have for lots of reasons. One being, though, frankly, policy has changed significantly, and the path to legal pathways have become much, much, much more difficult to access if you're from certain countries. So this is kind of the evolution of the proportion of immigrant children in the U.S. from 1990. And when I was looking back in 1990, I was like, oh, 20 years ago. No, 30 years ago. The young people don't understand that feeling, but the older people get it. So anyway, 30 years ago, we were in a different place than we are now. And this proportion continues to grow. But then always recognizing that we are still, the majority of these children, immigrant children, are U.S. born. And again, that gives you access to certain resources. Talking about different terms, and I always have to review these, and so it was a good moment for me to kind of go through this again. A naturalized citizen only comes out of being a permanent resident. So basically, you have to have permanent resident status to become a naturalized citizen, and then you can acquire all the benefits and responsibilities of citizenship. Permanent resident also provides you certain benefits. A refugee and asylee, not an asylum seeker, or not someone who's applying for asylum, but who has actually been granted asylum, they have different access to certain public benefits, and we'll go over that. These are children and adults who have been forced to flee due to persecution or fear of persecution based on being part of a group that they can't help being part of. And the difference between those is refugees are designated before entering the United States, so refugee status is designated before entering the United States, or asylum status is designated after you've entered the United States. Twilight status is our, DACA recipients, temporary protected status. There's something called SIJS, which is the Special Immigrant Juvenile Status, I think is the acronym. So there's certain categories that people can fall under that kind of gives them this twilight status, which is you don't have a path to permanent residency, which means you don't have a path to naturalization, but you can't get deported and you can do certain things. And then unauthorized is also synonymous with someone without legal status, irregular, undocumented, however you hear it everywhere. And that is someone who is unlawfully present in the United States. They may have come here through a non-legal channel or had come here with a visa, but then overstayed their visa. In California, and I don't think this will be a surprise to anyone here or anyone online, we have more immigrants than any other state. And 27% of California's population was foreign-born, and those are the counties listed there that have over a third of their population are foreign-born residents. So that's huge. Half of California's children have at least one immigrant parent. And just kind of speaking back to that naturalization pathways, they're incredible. If you can't get to that permanent resident status, then you can't be naturalized. But there are these special statuses that I think it's worth informing yourself on, and we'll touch on a little bit, because if you see that any member of a family that you're taking care of could potentially have any kind of pathway to legal status, that's really important in terms of what they're going to be able to access in terms of resources. So understanding that as us can really help the family you're taking care of. Although the majority of immigrant children are living in these 6 states, which I think aren't surprising to you. They are dispersed throughout the country, and so especially for the residents, so most of them want to stay in California. But anywhere you go in the United States, you're going to be taking care of immigrant children. We know that immigrant children face higher poverty rates, even if you have a working 2-parent household. We have barriers to public programs, as I'll touch on that a little bit more in some later slides. We have lower enrollment early education programs like Head Start, and we're less likely to graduate high school compared to non-immigrant peers. However, we know, right, and we've talked a lot about this with the residents, but that this has to do with like all these levels of social determinants, which ultimately like has to do with the policies that are in place, right? So if we don't have policies that allow access to healthcare, health is going to be poor, right? We're going to have poor outcomes in health. If we don't have policies protecting workers, because we have very few policies around protecting workers who don't have legal status, you're much more likely to potentially get like injured and then not be able to work, leading your family to be in poverty. And so all the policies have trickle down to all the other things like living and working conditions, and what the ultimate outcomes are. So children of immigrants are nearly twice as likely to be uninsured as children in non-immigrant families. It's a little different in California because we do have Medicaid coverage for anyone who's income eligible, but recognize that is state covered. That's not federally funded because federal Medicaid you're not eligible for federal Medicaid federal Medicaid dollars if you do not have legal status. Policies matter. I did want to talk about this for a moment, and I've had personal experience with a few families. I had a kid that I took care of probably like a year into the time I was in Ventura. He was about like 13, I think, when I started taking care of him, and his dad had been deported like 2 years before. This is a family that was already, low income, like kind of like meeting the threshold for many income eligible, like poverty programs, essentially, right? And overnight, one of those incomes was gone, and a parent was gone. And so you can imagine it was a family of 4, and then it was a family of 3. It was mom and her 2 kids, that this had major ramifications on that family. The older daughter was, I think, just slightly older and a little more resilient for whatever reasons, and was able to kind of get through high school and like get to community college. But he really, really struggled. And when I saw him, like his mom was just like terrified that, like, I think he terrified he was going to get into stuff that was going to ultimately like kill him or land him in jail forever. He was in and out of the juvenile justice system. And it was like heartbreaking, right? Because this had all stemmed from like dad being gone overnight. And so these are our families are just living in constant fear, and like particularly right now, right? But they're living in constant fear. And I think just as we screen for all the things, understanding that about our families really matters. I think it really matters that we help prepare them for the potential and help empower them to know their rights, and we'll talk a little bit about that. But that family separation, like certainly lost half of their income, if not more. I don't know how much dad was earning compared to mom. So then mom, had to get 2 or 3 jobs, and then mom's not present, right? So there's such a trickle down effect of what happens when a parent gets deported, and they're living in constant fear of this. So we'll touch on clinical care, and I think when we think about clinical care for any immigrant child, we really have to think about trauma-informed clinical care. And I know Dr. Hubbard gave a great presentation on trauma-informed care a few months ago, I believe. But I think just remembering that not only like the children, and so these recent arrivals that we're having come, and we see a lot of them at SBNC, and this has been a really nice like kind of bonus of moving clinics, because I hadn't had so many recent arrival children. I'd always taken care of immigrant families, but so many kids who really had just come here like a few months ago. But understanding that they are like, they're leaving their countries for really often very scary reasons. And if it's not the children, because the children are US born, the parents left because of this. So there is so much trauma in these families that we really have to take a trauma-informed approach. And so that is about relational care, right? Making sure that we're building that trust, even if it's the first time and the only time you're going to see that family. And I say that, the residents, that's sometimes what happens, right? That when you're with me, sometimes this is the only time you're going to see that family. But we actually have the luxury of time, and we can take that time to build that trust, making sure that we're involving trained interpreters, and we'll talk a little bit about using interpreters, and having a respectful attitude, and then also making sure that we are giving them choices, right? That we are really supporting that sense of agency, because there are few choices that they have often. So this is now going to speak to specifically these newcomer, like foreign-born kids, because we should. This is from the toolkit, the comprehensive history and physical. Like, if you kind of glance at it, you're like, yeah, I do all that, right? Like, sure, I talk about menarche. We make sure that we have gotten a birth history, social history, et cetera. But when you look at it a little bit more closely, I think it's really important to understand, like, one of the first bullet point is immigration information, right? What was your migration pattern? Like, who came with you? Like, I always ask that, like, who was the unit that came together? Because sometimes it's just a kid, right? Or two kids. And like, I'll talk to that in a minute. But I really think that it's important to look at those specific details that might be important for these kids. And so taking a moment to kind of look through this. But we do, the developmental assessments in our clinic. I know we do the developmental assessments. We do anxiety screening. We do depression screening, all things that are, I really happy to say, standard of care in our clinic. Should be done for all these kids, but we also have specific things that we need to consider. And again, these are things like, and this is important, I think, for all immigrant children, but often from specific regions. When you think about looking at their skin evaluation, the GU exam definitely can be deferred if it's the first time you're meeting them and there's hesitation. That's totally understandable. And, really making sure that you're having like close follow-up and being open to the fact that like maybe I'm just going to have them come back in like a week or 2 weeks, right? That's okay, to make sure that you are doing everything in like a manner that feels respectful and that they can feel like they can build that trust with you. This is, I don't remember which resident pointed this out to me, but this is a great one pager from AAP California Chapter 1. Thank you, Liana. You can Google this, Immigrant Health Toolkit, AAP California Chapter 1, because it's just like on one page. So, go through the toolkit because it's really not that long, but this one just summarizes it, and this is what we have up in clinic. And again, making sure that we're going through everything, and that comprehensive medical exam really should include questions on migration, trauma, and family separation. So I alluded to the two little girls. So we had mom bring in two sisters recently. I think they were like 11 and 9 or like 10 and 8, like young in my head. And I asked like, who came with them? Like, did you come? And mom's like, no, I was here. I don't remember what dad's situation was. But then they came and I was like by themselves? And like, yep, by themselves. And I was like, okay. And then they were held in detention, luckily only overnight. But talking about, like, you could see the like older girl kind of like shut down when we talked about that. And so we don't want to over probe or re-traumatize in any way, but we need to know that information. That's really important information, because like, we may want to refer to behavioral health. And we talked about that with mom. Like, maybe we are not seeing symptoms right now, but we may see trauma symptoms in the future. And this is important for me to know so we can make sure we help support, your kids and family in the future. Don't get scared. You don't have to screen for all of these things. They're just like, it's good to look at it and make sure that you're like, oh yeah, I've thought of these things. Because I had not thought of lots of these things much since medical school, like soil transmitted helminths. Like we don't think about roundworm and hookworm that often here, but it is very prevalent, and we do need to think about it. And this is kind of where they come. All the recommendations in the toolkit on what you should be screening for is based on real facts and data. Giardia, I think, is an important one to, again, kind of like keep in consideration. My co-chief in residency came back from the Dominican Republic. Her husband was Dominican. They had gone on a trip. I think it was like a few months later, and she came and she's like, "Oh yeah, I guess I have Giardia." And I was like, "Did you have symptoms?" And she's like, "Well, I felt like a little bloated." And so like she had kind of just like these vague symptoms, and she wasn't feeling great, and she like ended up having Giardia. So just it can be pretty mild and indolent. So just keep it in mind, and I think that's the important thing to think about with all these our recent arrivals. Strongyloides is definitely something I had not been thinking about, but I saw it in the toolkit and that we were supposed to be screening for serology. And I was like, well, but like serology will just tell me that they have it. Well, apparently you can have it for your life, right? So you can have this auto-infection, and so the recommendation is either actually to presumptively treat. Oh, there's these skin manifestations. I just want to give you some pictures because I think I might not have thought of this. So it was good to see these little skin manifestations, also some GI symptoms. And the recommendation is to do serology or empirically treat. We've been doing serology, and so far it's not like every kid has been positive, and so I think I'll probably continue to just screen and then treat anyone that screens positive. We don't know exact numbers. There's really like bad data on it, but there are estimates that 40% of the population in areas of the tropics and subtropics, which is where a lot of our kids are coming from, have this. So definitely worth screening for, and so easy because you're getting blood work anyway. So just screening for the serology. And ivermectin is treatment of choice unless they come from a low endemic region. Most of our kids are not coming from a low endemic region. Most of those countries are in Africa. But if you do have someone come from Africa and you are going to be treating, you have to think about this because you actually need to treat for loa first, because this is all stuff I just looked up because it was not something I had been thinking about much. Because treating with ivermectin, if you have loa can actually cause like encephalopathy. So don't do that. So important to know these nuances, and these are all in the toolkit. Schistosomiasis is something else I think you have to just consider, and again, the recommendation is to do serology. And you do have to rule out neurocysticercosis. For all, I'm sure people are like, oh yeah, I remember this from medical school, right? So thinking about that. And then malaria is the last one. Actually, I had a friend get diagnosed with malaria like 3 or 4, maybe even 5 months into our like junior year of college. Not surprisingly, he was like not doing well in his classes because he had just been sleeping and not feeling terrible. But it can be fairly indolent, and so it's really important to think about it. Again, it's just this idea is just think about it. There are recommendations from the CDC to do presumptive treatment for new arrivals from high-risk African regions, but most of the time they're not saying like do presumptive treatment, but you just have to keep it in mind. And looking at the map, when I think about like where a lot of our families are from, we're looking at, Mexico. We don't really have a malarial risk, but I think this is the border of Nicaragua and Honduras, and then the areas like Venezuela, Peru, Brazil, like essentially like jungle. So do think about it and understand and know where your families are coming from. Really, it's not the same to come from like maybe Mexico or Honduras, because it does change kind of how you're thinking. And then toxic exposures, definitely lead is the highest one to think about. We had a teenager, actually, Dr. Vermuri had a teenager recently who I think the lead level was like in the 20s. It was really high. And so the recommendation is to do lead screening on all kids and any age. And to really try to understand and get to like what could be potentially exposure, especially if you find that they're still elevated, even if they've been here for a few months already. Okay, so this is actually the pared down, that big chart with like all the things you might have to think about. This is the pared down version. So definitely a quantiferon, doing a CBC, lead, Hep B surface antigen. And again, you're looking for potential like active infection of Hep B, not necessarily that they have an antibody like they got the vaccine. I'm terrible about this, guys. The stool O&P, you're supposed to do 3, or you're supposed to do a presumptive treatment with albendazole, which I may start doing after I was like going through this. I was like, I'm not really doing the stool O&P. This is really hard to get them to bring it back 3 times. So presumptive treatment with like a dose of albendazole doesn't actually sound that hard. It seems like a worthwhile thing to do. And then we are doing the strongyloides serology, or you can do presumptive treatment with ivermectin. HIV and syphilis are for all kids. And this is actually in that nice, that's that one pager again, going back. And this is a nice little chart as to like, what for each age range you need to be doing. HIV and RPR to catch the congenital infections. And then in the sexually active teenagers, obviously you're gonna do gonorrhea, chlamydia as well. And then finally, again, when I looked at this, if you again glance at it, you're like, I'm doing all these things. I refer to WIC, I refer to dental, I do the fluoride varnish, I'm a really good pediatrician. But this is the part, like the little detail, right? How about you orient them also to the US healthcare system? Because that is very different than from where they're coming from. So we don't know how much access they've had to healthcare systems and what their healthcare system looked like, but it looked different than what we have. So I think making sure that either I orient them or I connect them with someone who can orient them is really critical. And this is something that I don't know that I've been doing a great job at and I'm going to work at. So hopefully I'm inspiring you all to work at it as well. All right, and then documenting immigration status. So we definitely would want to document like positive screenings, anything we're referring for, community resources, the referrals that we've made. But we do want to avoid like documenting like actual immigration status because that can be subpoenaable. I don't know if that's a word, but you don't want that necessarily in the medical record. And then best practices around language interpretation. And as I was going through this, I was like, oh, I did that the other day. I had a Ukrainian family. They came with like their family friend that they're staying with who also speaks English but also Ukrainian. And I used that friend because the family kind of like asked me to, but like I really shouldn't have. Like I really should have used a trained interpreter. That is best practice. So I'm going to hold myself to that standard. Please hold yourself to that standard. Don't use family members. Speak to the patient, not the interpreter. That's easier when we're using the tablet. And just making sure that you're keeping the language simple. You're doing a lot of teach back and making sure that that we're all on the same page. And I've had residents tell me, because a lot of our residents speak like a little Spanish, that sometimes they're like, I don't think the interpreter's doing a great job. Like I can tell what they're saying and they're not saying exactly what I said. Like don't be afraid to say like, thank you for your help, interpreter, and like dialing back and asking for another one. So that's okay too, if you feel like the interpretation is not going well. It's a little easier to do that than to dismiss like an in-person interpreter, but just make sure you feel good about the interpretation. All right, so talking about access to healthcare and public benefits, essentially I think I told you guys, when you are, and this is all from the toolkit. It goes over Medicaid, CHIP, ACA, SNAP, TANF, public housing. This is a nicer one. This is kind of summarizes it all, and this is from the National Immigration Law Center. Because I think these are the kind of two big chunks that we're going to potentially fall in under: refugees and asylees or victims of trafficking versus like undocumented. So you just have so much more eligibility for resources and public benefits if you have a legal status. So if you can at all get that, that's a good deal, good idea. The only thing federally you're eligible for is emergency Medicaid, which is a 30-day Medicaid thing, if you do not have legal status. Now, that is different in California, again, because we do have income eligibility for all people, regardless of legal status in California for Medicaid. But again, we are not getting federal dollars for those people in California. And even as we have that in place, we still have 27% of our undocumented residents in California who are uninsured. And this was as of 2024. What you do have right to as any child in the United States is a right to free and public education, K through 12. And this comes from a section of the Civil Rights Act. But this is really important to remember because kids can get a lot from school, right? They can, and schools are not allowed to like make kids scared and not want to come to school or like push parents to give them any proof of citizenship or legal residence or anything to enroll. Like that's not what you need. You need like proof of residence to like tell them what district you are in, but you don't have to say anything about your legal status. You're allowed to get like the free or reduced meals, which is huge for a lot of our families, special education. Our kids who are transitioning out of early start, like they have a right to the speech therapy or physical therapy or occupational therapy that is within the purview of the school. And we need to be making sure families understand that and know that, and we connect them. And so making sure we're doing all the screening, right? Asking about food insecurity, housing, healthcare access for both the child and parents. I have many parents who don't have healthcare access, and so we do try to connect them with health promotion services at our clinic because it's really important that everyone in the family have healthcare access, and making sure we're providing those referrals to the resources that they can get to and that they're eligible for. Assisting with applications is huge too, and again, that is not necessarily something that we can do in our very quick visits. But hopefully we can find someone or a community organization that's potentially able to help with that. The public charge rule. So this is important for you to understand, and so you can tell families. And I had a family recently ask me about this because they came in to, this is another office, but to pay out of pocket. And I said, I'm pretty sure you're income eligible for Medicaid. I mean, we talked a little bit about where they were. And the mom had said, no, like my husband says, we can't take any of that because then that would be held against us if we ever try to have a pathway to citizenship or like any kind of legal status. The public charge rule really has to do with very specific things that the government says we will hold it against you if you took like Social Security, for example, or like if you did use Medicaid for long-term care, so something like a nursing facility, right? So if you use those for those specific things, that can be held against you when we're looking at your application to become a permanent resident or citizen. But in 2022, use of benefits like Medicaid, CHIP, WIC, housing, like Section 8 housing, school meals, that they are no longer penalized. I don't know if that's going to change. But as of right now, and actually the prior Trump administration did try to change some public charge policy, and that was struck down by the Supreme Court at that time. So I guess I'm hopeful, fairly confident that wouldn't happen, that even if they tried to change it, it wouldn't happen. But as of right now, and I looked it up, now, all the federal, I don't know if you guys have looked at some federal pages, like all of the federal pages around immigration have a little caveat on the top that say like, this information isn't totally up to date, but it's here archived for your reference. So essentially there's no like up to date, like this is definitely the policy right now. However, this is what the U.S. Citizenship and Immigration Services website says, is that these are all not, they cannot be held against you if you were going to apply for a pathway to permanent legal residency or citizenship. You can take SNAP, you can take WIC, you can take CHIP, you can be on Medicaid, you can have housing benefits. And none of that should be held against you as of right now. We know that there have been significant immigration policy changes since January 2025, since it feels like forever, but it's only been a couple months. But the protected areas policy was rescinded, not in California. So I think it's, because this was a federal policy that we had protected areas, and that's no longer the case. And so we need to be ready for that. There's also, I think, all of the mass deportation talk, really, even it's just like talk, like instills this anxiety and fear in our families that we need to understand and recognize and not shy away from. And then understanding these are all kind of the different groups that there is limited power to immediately remove. There's a huge number of people waiting on asylum claims that will have to go through immigration court. And right now, I know I just got an email yesterday about a lot of legal aid organizations that were helping the children go through these asylum claims, like especially like unaccompanied minors go through asylum claims, are no longer funded. And so these kids will just have to represent themselves in immigration court, which was happening before. And then there was this huge push, I think, from lots of different groups to help try to support kids and provide them legal representation in court, because it's ridiculous for a 5-year-old to be self-representing in court. But we are now kind of losing that as funding has gone away for a lot of this work. In California, we still have state laws that limit cooperation between local law enforcement and ICE, and I know that I've personally seen a lot of videos from law enforcement in different counties essentially saying like, hey, we are here to protect you. We are not here to enforce immigration. Like, trust us. And I think that goes a long way when people are, actively going out to the community, particularly law enforcement actively going out to the community and saying like, we are here to keep you safe. Hospitals and clinics are still considered sensitive locations, but things like our administration did an excellent job of talking about this. at SBNC, and they said the waiting room, for example, at SBNC is public, and so ICE can come in there, but they can't come to the back unless they have a warrant with the correct address, so the address of the clinic and the person's name spelled exactly right and with the date of birth all right. All the information has to be precise for them to be able to for that legal warrant to be used. And I think understanding nuances like that is really key to helping protect really our families and our staff and anyone who might be at risk. This was a study done during the last Trump administration with the different policy changes that had taken place. And this was about 400 Latino adolescents in California, and just found much higher rates of anxiety, sleep issues, and even blood pressure changes. So this is affecting the health of our children in front of our eyes. And that was, I think, really with less scary conditions than we have even now. So the other side of fear is preparation, and this is actually from my friend Raul, who's the current chair of the Council on Immigration Health for the AAP. If we prepare ourselves, we can help prepare our patients. And preparing our patients does entail talking about this, talking about what are your plans if you were to be deported? Who are your kids going to go to? Just helping them think through those things is as much our purview as when we're helping. I took care of a lot of kids with special needs where we help them transition out of being 17, 18 and going to guardianship after that. Thinking through these things is hard, and yet we still really have to do it. We want to protect our patients, and so knowing the nuances like the warrant thing is really important. And then informing ourselves, our patients, and the public around all these issues. And so the AAP does this, right? And this is just a couple little instances where the AAP has been advocating. The AAP is constantly advocating for all children and pediatricians. And what underpins that is all the policy, right? So there's policy statements written. These are all the immigrant health policy statements that have come out in the last decade. This is what supports our advocacy, right? Because we can say, here's what the data we've gathered around health outcomes, around what is best for children, and this is why we need to inform policy. If you want to know more about resources, you can access this. This is a really helpful, kind of the most up-to-date website that I know of with different resources. I think it comes out of the Bay Area, but it really has resources and information that is relevant to all of our immigrant families. And then make sure you know about red cards, knowing your rights. These red cards are available in all languages. We're working to get them in our offices and specifically in our clinic rooms where parents could just take one and posters up in our clinic offices. And this is my reminder to work with our administration to get that going. This is something we had talked about. And then this is something that kind of I aspire to. I actually am not as aware of medical or legal aid organizations up here that can help with some of this work, but we should be aware. And medical legal partnerships between clinical settings and lawyer and immigration lawyers is so key to, again, if you can get one person in a family that you're taking care of, any kind of status, that just provides so much more access to public benefits and resources that they don't have access to right now. This is a nice little primer. These are from the Immigrant Health Council from the AAP, but this link is for a primer on how best to write those letters of support. And I've definitely been asked to write letters of support for immigration lawyers and making sure you're including the most pertinent and the most important stuff that they need to know. And then this is talking about actual becoming an asylum for a person who does medical exams for people who are applying for asylum. And then this is a little thing that I actually did because I figured I should do it if I'm going to tell you to do it. This is just committing to something, right? This is through also the AAP Immigrant Health Council. This it takes you like 5 minutes. You think through some goals as to like what you can do in your practice, what you can do, you know, whether you're in the hospital or a specialist, or what are specific goals that you can set that are SMART goals, and make sure that that you commit to something to help support immigrant children. So these are my references, and I leave those. Hopefully you'll be able to access these slides. But I'll leave you with this because I think about this a lot. I think about this with my own parents' journey. But I think any person who has like left their country, left all that they have ever known, left their culture and language, and comes here is brave. And I do hold this close to my heart whenever I take care of our immigrant families and children. Thank you.
Thank you, Dr. Ruiz. I am fortunate to be the question moderator for you today. That was wonderful. So much information. I'll have to watch the recording a couple times to get all of that. But that was really incredible and so helpful. We are so lucky to have you here. So thank you so much. I know we have a couple comments online, and then we'll get some questions. And here's a question. Have you had any issues with SynCal not covering testing?
No, not at all. No, not at all. I think I don't know what diagnosis we've been using. I'm looking at the residents I have. Like, I don't know. I've like recent immigrant. There is like a diagnosis of like recent immigrant or recent immigration or something like that. I think if you link the screening test to that, I don't think you'd have any issue.
Another comment. Thank you for touching on the importance of using a trained interpreter, not staff or family, and best practice. Appreciate you. Truly amazing. Lots of nice comments.
Thanks.
I'll ask a question. You know, in anticipation of moderating, I'm getting better at using Chat GPT. And so I said, what question should I ask? And this has popped up, but I want to take a twist on it. It said, what are effective ways for pediatricians to advocate for immigrant children without overstepping professional boundaries? And I was surprised by that because I'm curious on your interpretation, because I'm like, I think it is our professional responsibility and obligation. We're talking about children's health and all children. So even I have to say, ChatGPT got this wrong. You've given us lots of given us lots of examples of things that we can do, and I love the action-oriented charge that you left us with. But could you just speak based on your work in this area and with the AAP and the chapter about our professional obligation? This is very much our lane.
Yeah, I would say to ChatGPT, there's almost nothing like that. Like if we're advocating for immigrant children, there's almost nothing. I don't know what would be beyond my professional boundary, right? So I think, I will kind of allude to, I know that residents have talked to me about like a little discomfort talking about some of this, right? How do I bring it up? But that's so much of like, yeah, like there are hard conversations we have all the time, right? Like the first time you did like a heads, assessment, right? Just talking about sexual health, like all of it, like it's uncomfortable. Like it's a stranger, really, right? But we are charged with that, and like kind of we've given this privilege, and it's something that I talk about all the time with people who are like, "What do you love about being a pediatrician?" And I'm like, the privilege that I have that like. Families will tell me things that they like. I have parents have told me things they've literally never told anyone ever in their whole life. Like that is such a privilege that they have that trust in me, and like on a first meeting, right? And I think that understanding how to approach these like sensitive topics is like, yeah, it's fundamental to what we do in all of the care that we give, but particularly in this area, I think it is. Again, right to ask in a tactful way, in a way that's not re-traumatizing, but is very much in our purview and really our obligation to take the best care of these kids. And then when we go outside of our clinic walls, we absolutely have all the right in the world and really an obligation to be advocating for kids and the best policies for kids' health.
I have a question. Being an immigrant child myself, coming from Peru, actually, so
Oh.
Dan are here.
Oh.
My memory of actually getting tons of vaccines to get ready for go to school. That's one thing I know you mentioned. Some of these kids are coming without records.
Yep.
You have no idea what they're, what they come. So I mean, my memory as a 9-year-old being like shot up with a million things. Is just being aware of that thing where like, okay, they're enrolling them in school, which you have access to, but you have to have everything. And
You do.
and if you don't have record of it, then you're getting,
Everything.
these kids are getting a lot more.
Probably again because they've had their vaccines. Yeah, for sure.
Dr. Ruiz, do you mind just repeating?
Yeah, and so the
question for those on Zoom.
kind of the question comment I think was just remembering herself like the story of being an immigrant child and having to get all the vaccines for school here because and especially in California, they're required. There's no, it's very hard to get exempt. And making sure that all that, you have to do all these steps to have the right to public education. And yeah, that's totally true. And in fact, I remember being at the high school free clinic, Hollywood High School Clinic as a community medicine fellow. And the first time I had to give like a teenager I don't know, because they don't get any of the combo vaccines, guys. So I think she got like 9 or 10 vaccines. It was like horrific. And then she vasovagaled on me. So like, it's terrible. But also she wanted to be in school. Like she was like, no, yeah, do it. Like I want to be in school. So yeah, it is so hard. I mean, whatever we can do to get the records, we try to do. But we do make sure that, that they're getting all their vaccines. The kind of that middle age is great because we can give them some of those combos. So there's not many like actual shots. But yeah, the older kids for sure get like a ton, and it's really hard. And that is where I tend to focus at least that first visit on those required vaccines, because the ones that are required are different than CDC recommended. And we've been talking a lot about that with the residents because like I definitely want to get them all the recommended, CDC recommended vaccines like HPV and meningitis. Like, yes, absolutely. That is not my first priority when they walk in. I want to get them ready to be in school because that is what the parent needs. Yeah.
I'm wondering though now that I'm a physician, no longer a 9-year-old, that and if a patient qualifies for SENCO, and I've been doing this for 25 years, anything that if they qualify for SENCO covers everything. It's an impressive program. If you can do titers, if you're able to do a blood test and be like, wow, she has incredible titers to the tetanus and polio and stuff like that, whether that would even hold validity versus
you still have to do. So the question was whether if you can do titers on for vaccines for eligibility for school, and the answer is yes. But then you have to go in and write an exemption. And I just looked this up. We just had a patient like this. So yes, it is we would be able to do that, but we'd have to go in and do exemptions for all those vaccines, based on our clinical judgment that the titers are appropriate. So I don't know how, frankly speaking, like practical that is. I also like really, really stay away from doing exemptions as much as I can. But yeah, it would really have to be an exceptional situation, I think, for me to do that.
As a Peruvian doctor, I am very happy that you don't forget your roots. We have too many good things to share with our US people. I recall I was here in '86. I started here. I am the senior pediatrician now. And I know I was looking for my training parasites. And here, they never ordered parasites. And when I came here, all my friends in the Santa Barbara clinic, they said, oh my God, how you get all of this? You need to order. But they never ordered. But we have too many good things. I was coming from Children's Hospital in Peru, 1,000 beds, 1,000 beds. There is pavilions for 100 babies with measles. Today I listened that our dear friend Kennedy say, please, vaccine with measles. We saw the real measles. We seen people dying from measles, the hemorrhagic measles, measles in the brain, measles everywhere. We don't have here. That was the reason we say, no. But we learned. That was the reason people that coming from different countries, we have too many good things to share here. Thank you
Yeah.
so much.
Oh, thank you. Thank you for that comment. Yeah, I appreciate that. I think we actually were talking about vaccine hesitancy yesterday with the residents and talking about, yeah, I mean, parents of like really my generation, if you grew up here, you didn't see all these vaccine preventable diseases. And I think, yeah, making sure we take that experience and continue to remember to talk about those experiences is crucial. But yes, I think immigrants make up our country, right? That's who this country is built on, immigrants.
And diversity truly makes us stronger in every sense. If it's the multidisciplinary team, if it's ethnicity, very much we need to remind everyone of that. Dr. Kwan had a question.
I think I really want to say thank you. This is not just helpful for my future patient, it's also helpful to me. Like now I have my mom and dad coming from China to visit me, if any urgent things happen, I know what I can do. So this is really helpful. And what I feel really challenging to manage this family is when they first come here and the kids need to go to school, they come to us. And when they get their vaccine and they need like a multiple follow-up, but they don't come back. Either it's transportation, it's financial, it's many reasons. So I always wondering, do you feel like a telehouse? Do you ever use like a telehouse to address like this kind of situation to have like a multiple follow-up step? Is that helpful or not?
Sure. The question was about telehealth and whether that can be employed for kind of that close follow-up initially. And I think for some things, yeah, for sure. I mean, I think for some things like, kind of a telehealth for like just following up for maybe a developmental concern or like a social concern or like whether, how a kid is adjusting, absolutely. I think, for practical like vaccines, no, right? Like if they have to come back to get vaccines, they have to come back to get vaccines. I will also say that I often offer telehealth because as like a busy parent, I can't take off like multiple days like in a month to take my kid to school or to the doctor. But I often ask, and I will say families actually do want to come back. I think what we have to offer is a Saturday clinic, a later appointment, right? So I think our issue is not that they don't want to come back, it's that it has to be on a time that they can come back. And so I think that's on us as all of us as providers to find, those windows of times that our families really need us to be there.
We have another comment from online. Thank you for speaking about the importance and explaining to families the difference in the healthcare system, as well as their rights in schools, including the rights of children to attend school, even with medical conditions. Devin.
I'm Devin. I'm a social worker here in the hospital, and I appreciate you asking questions about, hey, what's your plan? If a parent were to be deported, what's your plan? And it just got me thinking about what questions should I consider asking when I do my initial social work assessment for patients. I feel like part of me thinks, oh, that would probably be better to be figured out in an outpatient setting when they have their ongoing relationship with their providers, but I can't always rely on that.
Yeah.
So I guess I wonder if you could list off maybe a couple other questions or topics you would recommend that we do try to touch on with some of our immigrant families.
Yeah, thank you for bringing that up. And I value so much like when hospital medicine got on board with like screening for like food insecurity and housing insecurity, because sometimes those things sometimes the conversation, it is nice to have like a trusted provider that you can talk about it with. But I think like practically speaking, often families don't have a medical home. And as much as I want to give them that medical home, they just like don't have it, right? Medicaid bumps you off and like then bumps you back on, and then you're like, you're transferred to another clinic. There's like so many reasons why getting like a fixed medical home is hard for all families, but particularly our immigrant families. So I actually think the hospital is a great place to try to have some of those conversations. And I think, asking, especially if like they're recent arrivals, I think asking about like any like migration history, but doing some of the just general discussion around like, I think it can come up in that general discussion around like family support resources. Like when I hear like a family is here and they like have no other family here, then I get into like, oh, like what brought you to Santa Barbara, right? Like what brought you here? Like what kind of support do you have? And if somewhere along the line, often I think either with the intake, the HPI, you get some information that like maybe this is a mixed status family. That's where you can kind of touch on this. Like we're going to talk about some like, kind of immigration topics, not because I'm putting anything in the chart about this, I think telling them that, but because I want to connect you with the best resources possible. And that's how I try to frame all the conversations. Like we take care of lots of immigrant families. In fact, the majority of our families are immigrant families. I want to make sure that I can support you and our clinic can support you and connect you to all the resources that are available to you. And so I'm going to talk about some of these questions. But I think it makes perfect sense to talk about it here and try to like have them at least start thinking about it the same way that we would talk about with like older patients, like a pulse or like like these hard conversations that it's not a one-time conversation. So starting it here and then having that in the discharge summary that some conversation was discussed, it's nuanced how you put it in there, or even like doing a warm handoff to like whoever they're going to follow up with, I think is helpful as well.
Another question, thank you for this talk. Schools are strict about immunizations, but not so much lately about TB screening status. Any thoughts?
Yeah, I agree. I think on our kids who are recent arrivals, you have to do you have to do blood work anyway. Like you should be doing blood work. So getting a quantiferon is not hard. And so I think definitely we need to be doing it for like public health reasons, because there's definitely potential for TB from where a lot of these kids are coming from. I mean, we should do it. Even if the kid, even if schools aren't necessarily being as strict, I think we should do it. I think I probably am not as good about doing it for like all kids, especially kids who have traveled out of the country and for how long. And so thank you, because it's a call to me to hold the standard and make sure that we're doing it really on all kids, even if like school isn't being as like prescriptive about it.
I will make the caveat that in California, those immunization requirements are strict, and these protections for immigrant is excellent. In the middle of the country and in certain states, I can only speak to Kansas legislature, but we are fighting some of these things like in veto session right now. So we really are fortunate. So for our trainees, keep that in mind when you decide where you're going to practice. There are a lot of benefits, and I swear I can breathe easier here in California. I really appreciate how you included the trauma-informed care aspect. What are, in just your final words here, ways that we can reassure our families and help them have routine and regulate in this time of uncertainty?
Yeah, I think, well, the first thing I think for the kids is making sure they have that like trusted adult, right? Because like some of these kids like are seeing their parent, right, their mom or their dad for the very first time, or maybe, I'm thinking about like the recent arrival, right? Like maybe they haven't seen them for like 5 or 6 years since they were like little. They don't really remember them. So making sure that like the same way that you would work with a family who has a newborn on like that family bonding, kind of trying to create that for that parent-child dyad. And so I think it's really important to remember that and consider that they are their mom, but like they're not, like they don't know them, right? So I think that's really important. And then for our kids who are like here already and are just living in kind of this constant state of fear, and there's some really good books out there, by the way. I meant to like put this all in here, but there are really a couple good books that I really recommend looking at, and I'll mention that at the very end. But I think, making sure they have trusted adults, and that's part of making that plan, right? Part of saying like to the parent, like, who can your kid count on if you weren't here tomorrow? And making sure that those kids have those trusted adults in their life. Solito is a really, really good book about a child's migrant story. So good. I think the author's name is Zamora is maybe the last name. So Solito. And then I can't remember. It's an actress that wrote a book about her own mixed status family and the anxiety. She's the actress from orange is the new black, and at some point it'll come to me and I can tell people if they want to know. I can't remember what the name of the book is, but really good books on kind of the immigrant experience, both a child coming here unaccompanied and then living here as in a mixed status family.
Yeah, like we have patients mostly from like Latin American countries, but I do get patients from other random countries as well. So is there any like differences in the testing that we should do on various countries based on the risk?
Yeah, and so most of the screening tests are talking about like kind of the more low resource countries, right? So I think I had a family from like Japan recently. I think we have a lot of families from different countries also from because of UCSB, right? So there is kind of specifics to different screening, and that's in the toolkit. A lot of the kind of infectious disease screening has to do with coming from like lower resource countries. But thank you for that question.
All right, well, thank you so much, Dr. Ruiz, and I appreciate the challenge to, what I heard was we need to get comfortable being uncomfortable. I think we're all, especially those of us taking care of children, are very uncomfortable right now. And again, each person can make a difference in your relationships with families, in your relationships with your colleagues, and then really we have a responsibility to let our decision makers know how these policies are impacting children. So thank you for all the work you do in the AAP, and we're so lucky that you're the California Chapter 2 president, a great example of an advocate. So thank you so much.
Thank
Wonderful.
you.